Jet, please.
Sure. Istvan introduced this panel by talking about the different social determinants that intersect with each other. And one factor that I did not hear mentioned was family structure. I'm curious, I feel that it's transplant for both living donors and recipients. You often have kind of a normative ideal of having one designated caregiver or support person. And people have a variety of family structures. They may be single, they may rely more on an extended family, they may be part of a diaspora community where their immediate family members are actually living overseas. I was wondering if any of you have explored how that might affect access to transplantation and whether it's something you would consider a modifiable factor.
Here is, sorry.
So I will start, and I guess I will pass it on to Lydia-Joi. We have been collecting data and numbers about this, and I didn't mention, although I think it was on that busy slide, that we know that marital status, traditional marital status, having a partner, a common law partner, or a wife or a husband, will increase your chance to get a living donor transplant by about 50% or more. Also, having family members around, the number of family members around, or the number of family members that you are in regular contact with, again improves your chances. But also, I think this is something that we'll need to revisit, reconsider, because family and family structure may mean different things in different cultures. And I guess Lydia-Joi may have some further explanation about that.
That was actually one of the first introductory conversations we had. It was very pleasant, just kind of speaking about what does support look like. And we were saying sometimes that's one of the barriers to access to care. Even when we're talking about screening, we assume like somebody who is single or somebody whose cultural idea of support looks different, they might be ruled out or considered don't have enough support because it's not in a North American context. And we were actually speaking about, I had a personal experience with this when my godbrother needed a transplant, and they kept asking us, well, how are you related and how is this? And we ended up like we'd make up stories. I'd be like, oh, I'm his wife, I'm his cousin, I'm whatever it takes for you to put him on the list, right? And so we were talking about sometimes it gets to a point we need to understand whether you're asking these questions for a social support reason or for a biological reason, and be able to explain to people what's the difference so they're able to respond correctly and say, yes, I'm supported, whether it looks like what you're used to or not. Okay?
I would absolutely echo that. Certainly an experience in a number of different populations is how do you define the definition of family, and then the way it gets obscured and the way it gets mixed up. Are you asking this because biology is important, or or are you looking for support? And then we've heard living unrelated transplant people don't need to be related to get good outcomes, and I think we've done a lot to sort of not encourage that connectivity within various of racial groups in terms of well, that's different, and that's not really what we're talking about. That's not the way I would want to do it.
Okay, thank you for those answers. Before we go back to the room, I'll get back to you. There is a question here for Dr. Landsberg. Are the live donor liver transplant program in BC taking a similar approach to what you described for kidney?
I'm a kidney transplant expert. We do have a living donor liver program, but it's not as well developed in BC as it is here. I would say definitely UHN is a leader, or the leader, and something that we can model well after.
Okay, thank you.
And at the Society's AGM, Dr. Gill mentioned the difference between the living donor follow-up in BC and in Ontario. In Ontario, a living donor, seemingly 21 days post-surgery, is handed off to a GP who knows 2/3 or 3/5 of very little, about living donation, and that's the end of it. In BC, I understand it's different. Could you speak to that?
So to some extent different. We have as I talked about, we have a provincial database, and so all of our donors are tracked for life. We do not see all of our donors unless there's a problem, but when results come in, we review them. We have a program where we send a letter to donors once a year saying, it's time for your blood work. We ask their GPs to send us their blood pressures. We want their kidney function. We want to know their blood sugars, and we want to know their blood pressure. If there's a problem, we bring them back or we refer them out. So, but it's up to we don't do it's passive. We send out the letter, but I say to people, we don't, but I don't come to your house to take you to the lab to do your yearly blood work. And so, that's better than nothing. But right now, I would say only about 65% of our donors actually do their donor follow-up.
In fact, that's somewhat better than 0%.
Absolutely.
Is it your sense that improves the sense of confidence in both donors and potential recipients, potential donors and potential recipients, as to the process? That if something goes wrong, God forbid, they'll be tracked and they'll be treated the way we are. Recipients are treated great. I couldn't ask for more as a recipient. My wife, who's the donor, gets nothing. That worries the heck out of me, and when there's a problem, it's hidden. The system doesn't seem to want to deal with it.
So I hope so. I don't have data to back that up. It's obviously my belief. One issue in living donation, really is for many recipients the reluctance to accept the gift because of concern about the long-term health of that person, and rightly so. I believe that everything that I can do to reassure them that we're on top of it is helpful, but I don't have data to back that up. But it's still the right thing to do.
Mark, do you want to make a comment about the follow-up of the liver live donors, which is a bit different than 3 weeks in here?
Obviously, as we said earlier, donor safety is our priority. When we first started the program, we did follow our donors with the intention of doing it lifelong. And we had a family doctor that worked with us very closely, Dr. Adcock, and we had this database that we well maintained, and we made sure we had all the blood work. But it became quite clear to us that after doing this about 10 years, most of the donors, beyond 10 years, didn't really want to come back to see us or have blood work. And fortunately for us, the liver does regenerate, and there are no functional concerns, from the liver perspective at least. So we've stopped that practice. So our current policy is when they're discharged from hospital, they're seen again by the surgeon who did their surgery at about 4 weeks. And at 3 months, they come back. They have another series of lab tests, as well as an MRI to make sure the liver is regenerating okay and there's no biliary tract problem. And then they're have another series of lab work at 12 months. We have contact. We, first of all, ensure that they have a family doctor. And we provide educational material for the family doctor, and they're told that they should have their liver tests monitored annually. To date, we've never seen a problem in any of our donors.
Yeah, thanks for clarifying that.
Just one comment from the kidney side, although Sunita is not here, and I know that she's working hard with the Center of Living Organ Donation to develop a follow-up program for the kidney donors. Again, there might be some more potential risks in donating a kidney long-term than long-term liver complications, although the risks, as it was mentioned, are very, very low. But we want to make sure that patients or donors are followed. But also, as you said, it's also about the perception. If it reduces anxiety, if it improves donation willingness through that, or acceptance through that perception, modifying perception, I think it is an important.
You and I both work with statistics, and we deal with things on percentage of risk. The problem is that when you have a problem, the risk is 100%. And that's what we have to remember when we deal with patients. Donors are patients too. They're being cut into, they're in perfect health when they show up, and they're in somewhat different health when they leave. I'm not only concerned here about renal function. I admit renal function is generally extremely good, and when it's not, it's often caught. There is a problem with the system, which is that there's not a great deal of funding, and GPs have to allocate their resources. Rural GPs are really afraid of taxing their resources by doing creatinine tests. They don't do them manually. They're reluctant to do them. But that's not always the biggest problem. The way we do surgery can be a problem. We have to push things out of the way. And so there are post-surgical complications which may not be renal, but are due directly to the transplant. Those should be tracked as well.
Yeah, I agree, and this is going to be part of our follow-up as well.
I'm the transplant assessment coordinator for Toronto General for the kidney donor program. Just to clarify, we do see the donors at the time of their discharge. We also have follow-up with the donor nephrologist, so the kidney donor physician at 3 months and 6 months following the donation. And each donor is provided with requisitions to do blood work and urine tests prior to each of those assessments. We also offer each donor an assessment on an annual basis. Dr. Singh's been really promoting that. And frequently, we have donors that do not follow up with us. For instance, last week, we had 5 donors scheduled for their 3-month and 6 months follow-up, and they just don't want to come back for that follow-up return. We also offer for anyone that has a concern that they think is associated with their kidney donation, or if their practitioner believes is associated with their kidney donation. They refer back to me, I triage that call, and I refer it either to the donor nephrologist or to one of our transplant surgeons.
Julie, thank you for this clarification on the follow-up.
Just if I may add to what was discussed, I was in a situation where I donated in Montreal. So my transplant team is there, and they've always said if anything happens, you have worries, concerns, whatever, you can always come back to us. But I live in Toronto, and a lot of my workup was done at Women's College Hospital, not at Toronto General or St. Mike's. And then after the surgery, when I did want to talk to a team, it was actually tough to get into the Toronto General to get some kind of follow-up. So maybe food for thought is when transplants are occurring between provinces, is making sure you have the open doors for living donors wherever they may have donated.
Thank you.